So we've talked about the addition of rituximab to purine analog. And we've talked about the fact that it's really not necessary to switch from cladribine to pennistatin if you use cladribine the first time, or pennistatin the first time, to switch to a different purine analog. Let's talk about the use of vemurafenib in hairy cell leukemia. And we could also talk about the treatment with combination BRAF MEK inhibition, which both of us have had some experience with.
So I think the discovery of BRAF mutations as being almost universal in classical hairy cell leukemia has been one of the most exciting events in hairy cell leukemia, especially that the investigators from Italy, Dr. Tiaci and Fellini, have shown in beautiful studies that this mechanism or development of BRAF mutation is pathogenic in the development of hairy cell leukemia and in the development of the hairs of the hairy cells, and also have shown that using effective BRAF inhibition, you can actually effectively kill the hairy cells. And also in beautiful elaborate experiments, they have shown that using BRAF inhibitors, you can actually make the cells lose their hair, which is very exciting and intellectually very important development. The first study of vemurafenib, which is a BRAF inhibitor that was actually developed for melanoma in hairy cell leukemia, there was 2 studies that were published in New England Journal of Medicine showing that this agent is truly effective and does produce responses. Now, this is an oral agent, and the advantage is that it doesn't produce a lot of myelosuppression. But the disadvantage, in my opinion, is that we still don't know how long the patient should keep taking the drug. Perhaps when we use it in combinations, you mentioned the combination with the MEK inhibitor, trametinib, of another BRAF inhibitor, dabrafenib. We both participated in this study, and that is a truly remarkable combination and produces, in my anecdotal experience, amazing responses in multiply relapsed hairy cell leukemia. Also, there is a combination of vemurafenib with rituximab that has been conducted in a clinical trial by the Italian group, showing that when you add the rituximab, you can actually perhaps shorten the duration of vemurafenib use. So I think these agents are clearly exciting and effective. My question is in terms of their duration of use as well as the cost of therapy. Perhaps if you think about it in terms of comparing it to cladribine, which is now a very cheap agent, clearly the use of such expensive oral, potentially long-term agents could be highly expensive in treating hairy cell leukemia.
Right. And these agents also have significant side effects. In the vemurafenib case, we can see squamous cell carcinomas and other skin problems. In the dabrafenib, trametinib case, we see fevers, and there are other side effects that can be quite annoying for patients, particularly if they have to get it long term. And long term seems to be the need in patients who really want long-term control of the hairy cell because these BRAF inhibitors are not known to eliminate minimal residual disease, at least by bone marrow aspirate flow. And although we've seen this occasionally, we haven't seen persistent elimination of minimal residual disease by all tests. And then we've also seen patients who've been MRD-free just instantaneously, but then they develop a positive MRD we've seen those patients relapse if they don't stay on treatment. So that tends to be a disadvantage, although the use of rituximab now, which is being tested in clinical trials, may change that. We'll have to see.